Hi, everyone, and welcome back to our next episode of ReWalk's Topics in Neurorehabilitation webcast. I'm Kathleen O'Donnell, and today we'll be talking with assistive technology expert Kyle Walker. Kyle is a certified ATP and is currently the VP of Rehabilitation Program Development with VGM Homelink. Prior to joining Homelink in 2018, Kyle worked as an assistive technology professional with Unity Point Health. Kyle currently holds his ATP certificate, a bachelor's degree in kinesiology from Iowa State University, and a master's degree in healthcare administration from Purdue University. He is a passionate advocate for patients and providers alike and regularly presents on numerous assistive technology topics across the country. In his free time, Kyle also volunteers his time by coaching youth sports, helping with adaptive sports programs, and is the Soldier Family Readiness Leader for his wife's Army National Guard unit. His talk today will introduce many of the considerations that go into proper wheelchair selection and positioning, and provide specific examples of some adjustments that can help to address common issues. Hi, Kyle. It's great to talk with you today.
You as well, Kathleen. I'm happy to be here. Thanks for having me.
We're glad you're here. Kyle, I'm really looking forward to your talk today because proper wheelchair seating and positioning is such an important topic in SCI rehabilitation. And I know we've all seen firsthand how much of a difference the right adjustments can really make for wheelchair users. And to our viewers, we'd love to hear from you as well. So, what are some of the common seating and positioning challenges that you see with your patients? And then maybe what are some of the techniques that you use to address these issues? So we'd love to hear your thoughts, and don't forget to like and subscribe to this video if you want to hear more talks like this one. And with that, Kyle, I'm going to let you take things from here.
Sounds great. Okay, well, again, thanks, Kathleen, for having me here. As I think probably a lot of our audience knows, with different interventions and modalities and products, it's complex. And we're going to talk about the complexities of complex rehab today, specifically in the seating positioning aspects of those. Today is going to be a brief overview. You can imagine you could spend hours and hours just talking about the cushion or the back. So this is an overview to talk about, as you said, some of those major takeaways and those most important factors, really trying to ensure, the best possible outcome with everybody involved, with the whole care team. It's a multifaceted approach, multidisciplinary, and that's what we're going to provide a little bit of insight to today. Before I get started into the presentation, I want everybody to know a little bit about me. I think it helps to, let's say, calm the nerves, but no, I'm just a normal guy, just like anybody else out in the market. That's my wife and my kids. I've been married for 7 years now. My oldest son, I think it's an outdated picture. He's 13 now, just turned 13. My daughter's 5. Jaden plays piano and sax, and very left-brained outside of myself. I grew up doing a lot of sports. He's very instrumental. My daughter loves activities and does cheer and that kind of stuff. So just a little bit about me. I live in Eastern Iowa, but really love complex rehab, what we're going to talk about today. So when we look at that holistic approach, again, multidisciplinary, we've got to understand all the players involved in the intervention, in the provision and procurement of that equipment for the best possible outcome. Obviously, that patient, and I'm going to use several terms with that today, not only patient, but sometimes claimant, sometimes consumer. They're always the consumer. Our role, a lot of times, not only as clinicians, but as ATPs and suppliers within this, is to educate and understand all the variables that are involved in it, or at least to the best of our knowledge. We also oftentimes have, obviously, the practitioner. Again, that could be a PM&R doc, a physiatrist, or even general practitioner. We see that a lot of times too. The family, depending upon the age and the injury, whether it's congenital or an acquired spinal cord injury, as we may talk about, the family is a very big piece of that. And oftentimes the family plays that caregiver role. Oftentimes there's other caregivers. We've got to really understand what their needs and who's really involved in this procurement and evaluation process. When we take that a step further, we've got to say who's actually present at the evaluation. For those of you newer to the complex rehab and mobility realm within seating positioning, whether it's manual or power wheelchair application, Oftentimes, there's going to be an actual formal mobility evaluation conducted by a PT or OT who specializes within that realm. Oftentimes called per Medicare's LCDs an LCMP, licensed certified medical practitioner. Again, it has some education and exposure, but not always. Oftentimes, the ATP is involved in help educating that clinician on what to look for and how to address these needs. Oftentimes today, we see actually in light of the pandemic and the public health emergency, telehealth and telemedicine has become ever so more present. And regardless of the method or location, it's imperative that we address the needs regardless of what modality we're using to look at those things. So if it is virtual, we still have to look at some objective tests and measurements on the placement. I will say, from my own point of view, still does not compare to being hands-on with the patient. And we're going to talk about a little bit when we get into the actual evaluation piece to look at the best outcome. What are those major features here? I can't stress enough how important it is to have an ATP, an assistive technology professional certified through RESNA, involved in the evaluation and procurement process. Through my sister company, US Rehab, who is a member services organization with the complex rehab communities, independent providers across the United States, they, in collaboration with the University of Pittsburgh, have an outcomes tool called the FMA. It's the Functional Mobility Assessment. The FMA is a tool that looks at I'll say the health-related quality of life metrics and scores post-provision of that equipment. And what we found, one of the variables we look at was an ATP involved in that process. And we found that with an ATP, there's two major takeaways. Granted, there's a lot of other things that we can look through that survey as well. One being we have increased HRQOL scores, as well as the equipment lasts longer. Two major things, one from the clinical perspective and social determinants of health, other from a monetary aspect in terms of cost from a payer perspective. It's very imperative to have a certified, educated clinician and ATP involved in that process for the best outcome for that patient. So if you guys are ever going through that process and don't have an ATP involved, I highly encourage you to look at that. Now, based on CMS's LCDs, there are times when they actually require, if it's a Medicare, Medicaid type insurance, an ATP to be involved, depending upon that, I guess, complexity or depth of equipment. Other times there's not. But even without that, all these scores are showing that regardless if it's an entry-level manual wheelchair or even a scooter or POV, having ATP has better results. As I was speaking to earlier, when we come into the evaluation with the different players, the settings, the major focus is looking and talking to the patient and the care team, the family on what their goals are. Ultimately, again, they're the consumer. And I can't stress that enough, how important it is to make sure we understand what their needs and intent is. As we do that, we also have to understand the policies in place. There are many times where, as a clinician, which you should, is always advocate for the patient and what's in their best interest, but you've got to also understand what you can and cannot do. Ultimately, at the end of the day, they're the consumer, they're going to make their choice, and I can recommend and I can give them information, but they're the one that's going to make that decision. So when we're involved in that process, after we're looking at the history, the clinical history, the prognosis of that patient, what if it's a new spinal cord injury patient, right? We know there's going to be changes immediately. But then over time, there's going to be muscle atrophy and other things we've got to take in consideration and hopefully mitigation of contractures and other things. But we've got to look at that too and identifying what do they want to do? Are they getting back to a level of former independence? Are they trying to gain independence? Are they trying to gain mobility within certain environments? Again, we've got to understand that as the clinical team as we go into that evaluation. When we're talking about that evaluation, again, you're going to hear a common theme here is peeling back the layers, asking those questions. You've been a clinician for a long time, been a therapist, you know the ins and outs of it. And I've fallen guilty to it myself sometimes where even it's a replacement for a patient that has a spinal cord injury, replacement K5, an ultralight wheelchair, under assuming that they just want the same thing and nothing's changed. If we don't do our diligence and ask those questions, what's changed? Where are you going to be using it? Those in-depth questions, if we don't ask that, we make that assumption and it can lead to negative outcomes. So I think we've got to always ask those questions on how they're using it, what is their intent? What is their goal? Um, so I guess that's the only point I want to make with that piece. When we look at the actual assessment, when we're in clinic, let's say we're doing a formal mobility evaluation. Um, everything, I say everything, a lot of it's going to start in the hips. The hips, it's kind of a generic term used for the pelvis, right? We know that the lower extremities and the spine is going to follow suit. So when we're doing a mat evaluation, literally, if possible, understand everything's situational. We need to get that claimant, that patient, that consumer out of their chair if they have one and onto a mat. We've got to have some manual manipulation of the pelvis to look at how they're positioned. Do they have any obliquities? Do they have any rotations? We've got to look at that for their positioning within the chair. Understanding that, as we talked about earlier, those goals, and what's their functional goals? What environments do they need to access? And how is this positioning going to hopefully allow them to do that? Again, very, very important to look at that. Like I said, the spine follows. Do they have a scoliotic back or a kyphotic or lordotic back that we need to take consideration for the back implications? And when we start with the pelvis, in the manual wheelchair application, it's very important for the upper extremities. That's our propulsion mechanism, right? And putting the right placement on the hand rim, so we have the most access, the most efficient propulsion stroke and technique. When we look at a power chair application, it's important because the majority of our consumers will utilize a joystick, traditional joystick to move. However, though, there are many that have progressive neurological conditions that will use alternative drive controls, such as a head array or a sip and puff type mechanism. And if that placement of that pelvis is not right, they won't be able to access their headrest to drive or reposition themselves. So again, we've really got to focus in that pelvis and see what we're looking at there. As I was speaking to those environmental considerations, or ADLs, we know the terminology, but I'm going to say it for those of you that don't, your activities of daily living. I'm going to take it a step further to say MRADLs, your mobility related activities of daily living. So we got to look at, again, what does our policy allow us to acquire or to recommend? I reference my experience lately has been within the work comp market, and we don't necessarily in work comp have policies in place like we do for a CMS type insurance to say we can only provide and recommend a piece of equipment needed within that home environment. In a work comp market, we could do stuff outside in those environments. So we've got to understand that, what the needs are. What were they doing prior to the injury? That are they trying to get back to that now? Those are absolutely imperative. A big, big piece of this is the transportation, getting out in the community. The FMA data or report, does look at some community involvement. And it's so, so important to look at a new injury, for example, a spinal injury. We may recommend an ultra lightweight K5 chair that's maybe folding initially because there's still a lot of unknown variables that they're going to encounter over the next several years. Over time, as they start getting more comfortable and how they utilize that chair, what the method of transportation is going to be, what that vehicle is, what those environments look like, then we can be more refined. Many times I had patients that had a spinal injury for 15, 20 years. They know what they want. It's worked really well. And I am a big proponent of that. I'm going to use the phrase, if it's not broke, don't fix it. There's no reason to do that if it's working well. Oftentimes I've found that less is even more when it comes to restraints and positioning. The reason we want to potentially limit from that is for proper positioning and reduction of harm to themselves or others. If there are some TBI type brain injured patients that don't have the ability to do that, or it's to increase function or increase access to their environment. A big thing that I kind of an aha moment I had in my career was when we were looking, I actually did an evaluation in a clinic setting for a manual wheelchair, and we said, oh, we're going to do this chair with solid insert tires because it's low maintenance. And then the next step of that is me going into the home to do a home evaluation, which I'll take a step back for a second. I think there's a lot of opportunities. My plug here for telemedicine, telehealth visits to do stuff prior to this so we can be more efficient and effective in our evaluation, to look at things prior to going to that 45, 50-minute window of evaluation with that PT or OT. I think we can do better as an industry. But with that example, I went to the home and noticed they had plush carpet throughout their whole house. even in the bathroom. It was an older person, and boy, that chair is not going to work very well in that environment. So it's again, you've got to peel back the layers, look at things holistically. As we go through that evaluation process to look at all the variables, um, then we look at that product selection. Okay. Um, One of the things that I want to stress is objective measures to trying to paint that clear picture for the reviewer if it's the insurance. Okay. And a lot of times, if it's a CMS insurance, we've got to show progression from the least costly, most effective piece of equipment. Um, for example, starting with a cane to a walker to a basic manual to maybe a K5. You've got to show that product progression. Regardless, you and I know spinal spinal cord injury patient is not probably going to be able to use a cane. Again, case by case, but we know that. But we've got to actually address that. Um, the other pieces is I've seen this, and it's sometimes a tough conversation. Again, a lot of it's dictated by the policy, but majority rules. And I say that yes, it'd be ideal to have multiple chairs, multiple pieces of equipment for different environments, paid for by insurance. In reality, many times it's not available because the policy will not allow that. They will pay for one piece of equipment. So we look at, hey, yes, maybe you, and I hate saying this because I want to advocate for the patients all the time and want them to be allowed to do the things they used to do or prior to their injury. Is maybe they like to garden and get out. In Iowa right now, it's cold as heck. Not now, but in the spring, they want to get outside. We're cooped up for so long, but we can only qualify someone for equipment that's needed within their home environment. Okay, so we've got to look at, okay, what's the 80% of the time? What's going to be that most effective intervention and piece of equipment? That's what we've got to look at as a care team. But there are other funding resources available too for these other pieces of equipment that maybe wouldn't be initially funded by their insurance. I think it's just important to look at what's the majority, what's going to be the most effective, and then the last thing I'll just continue to reiterate is they're a consumer. They need to be involved in this process from the beginning. We need their feedback and we need their engagement. I'm going to show you just two practical examples that I've dealt with many times over my career thus far. One is with a patient that has kyphosis, right? The rounding of the back. There are lots of implications from having this diagnosis. One of them being vision. You and I, majority of people in our community utilize our vision very, very much throughout the day for lots of things, not only psychosocial, but also for their ADLs and their environment. When we have that kyphotic back, their vision comes down because they don't have the range of motion. Obviously, there's a spectrum, right, in the severity of this kyphosis. But through some interventions, and actually, it's encouraging these days. There's a lot of off-the-shelf OTS type products that we don't need custom molded seats these days. We can accommodate and help correct a strong word to use, but we can accommodate that curvature through some products. This is a back from comfort company owned by Permobil right now, but they use these cabling, so you can actually capture that, and it can be dynamically adjusted to help open up that field of vision. And not only the vision, you can access, maybe it's from a manual wheelchair perspective, the hand rim better, or maybe it's in a power chair because you can apply these to a power chair and access your joystick better. These are really encouraging things again that don't need a lot of customization, but we can look at this method to help accommodate some of that. Unfortunately, a growing trend that I've seen over even my last 7 years now is a bariatric client, and with that are lots of complications. The big thing that I've experienced, unfortunately, is from a policy standpoint. And I know I've said that several times, but just because their home may not be able to accommodate that wheelchair because it has to be larger, whether it's manual or power, I can't necessarily provide it as a CRT provider because their home environment won't allow the chair to go in their functional areas, or their kitchen, living, or main living areas. So that's very important to understand the actual footprint of that device within their home environment. We look at some actual clinical or product pieces of that to the positioning. Oftentimes we have a large gluteal area, right? So some adipose tissue, but that prevents them, if we have a traditional, trying to do a visual here, a flat back, there's a gap, right? And I can only imagine my back hurts, let alone being maybe a larger individual that's maybe morbidly obese. So we can make a modification to that back to allow them to recess further into that back with a gluteal shelf. Another thing, very important thing, whether it's manual or power chair application, is the weight distribution, the center of gravity. A lot of bariatric chairs in a power aspect will actually shift that drive tire, instead of being in the middle, more forward, kind of a hybrid, to help accommodate that center of gravity need. Oftentimes we see some lymphedema, and especially in lower extremities, and then it causes the legs to splay out, obviously increasing the width of that chair or their footprint in that environment. So we can put some anterior, I guess I would say, lateral hip guides or knee guides to keep those legs in. But those are some considerations too. There's lots of things we've got to think of holistically, depending upon that patient. Again, addressing the goals, the needs, and the ability to provide that equipment based on what policies or insurance that patient has. Those are just a few tidbits here that I guess I will stress, Kathleen. There's my contact information. If anybody has any, Kathleen, I'm sure you'll share it maybe later on as well. But again, I'm very passionate about this, not only because I've worked with the consumers in the field, in their homes, had some very tough conversations with them about some life-altering injuries, and I just would always continue to advocate for the patients. And in my role now, I understand there's a lot of other variables to take consideration. And so anything I can do for anybody that's listening, please reach out to me. I would love to connect with you and pick my brain or however I can help. So.
Thanks, Kyle, for a really great talk and some really nice insights from your personal experience. I think obviously it was clear there's a lot of considerations that need to be taken into account when we're looking at things like wheelchair seating and positioning. And so I think it was nice to have just kind of a broad overview and kind of a nice summary for all of this. Just wanted to ask you a few follow-up questions.
Sure.
And the first one is, I think just like with any other assistive technology, a lot of our success really comes down to making sure we really do a proper evaluation of, what that patient's individual situation is, what their needs are. You emphasize this a lot in your talk. I'm curious, what are some of the specific assessments that you would recommend therapists be prepared to perform during that mobility assessment and wheelchair evaluation?
Sure.
And is there any other information that they could collect sort of prior to that evaluation that would be helpful to bring as well?
Well, that's a great question, Kathleen. I appreciate you asking that. As I alluded to earlier, one would be, again, exploring telehealth. Can you have information prior to the appointment from that CRT provider? A lot of times, there's going to be that CRT provider from a DME organization in their community that's already engaged with that patient. What information can they give you prior to that evaluation so you can come prepared? Again, I think with telehealth, you can do some of these unbilled or non-billable assessments, such as your home evaluation prior to, and having this almost a triage call so you know what to expect. Unfortunately, I mean, in my experience, we often come in blind. Even I do sometimes before that appointment. So being prepared is a big piece of that. Again, for the most effective and timely evaluation, as well as the best outcome, I really believe. When we look at the actual evaluation, things that I would highly, highly recommend, again, the intent is to paint a clear picture for insurance, because we have to submit majority of these for an ADMC or a prior authorization. So by doing that, we got to make sure we can be as objective as possible. So basic stuff that you're familiar with, Kathleen, is a range of motion, upper and lower extremities. Maybe it's the head, maybe it's the torso. Manual muscle test. We've got to perform some of those to look at the strength in your shoulder and your arm for a manual application. And then, again, depending upon diagnosis, maybe there's a DGI, a balance test that we could use, or any ambulatory type tests. Propulsion, strokes over distance over time. It could be even as simple as an oxygen saturation test, or an RPE, even looking at this activity versus the other to help justify that. So those would be my recommendations. Again, anything objective you can put into those notes.
That's great. And I think just with everything else, it comes down to really being able to quantify and document for insurance companies, I think is a
Absolutely.
big part of it. It sounds like. You also brought up a couple of practical examples of specific scenarios that you've encountered where equipment-based modifications can be used to address some of the common challenges. But I'm curious, are there any potential issues that therapists could work on to address with their patients sort of prior to that
Sure.
wheelchair assessment that maybe would eliminate the need or reduce the need for some of these modifications?
I think a lot of it is going to be situational, and that makes sense, depending upon the diagnosis and then prognosis of that patient and what that may look like. But things that I've experienced, at least working in a PM&R clinic, are those physical medicine docs, or just physical medicine in general, whether it's PT or OT. Post injury, those are very key to look at their actual range of motion potentially if they had a previous contracture. Sometimes we dealt with I oftentimes actually deal with the clients that have tone and spasticity issues. So there are different therapies and modalities to help mitigate some of that, which will help in their positioning, within that relatively constrained environment in their chair. The other thing that's very important to understand is wound care and wound management. There are some products on the market that will help mitigate and help to heal current wounds, but we don't want to ever get there. But that's important to be cognizant of as we're going into that and reducing that pressure and having a best distribution of that pressure profile as we're placing them within that piece of equipment.
That's a great point. And I think you have kind of a unique pathway that you've gone down with pursuing that ATP certification. For any of our viewers who might be considering pursuing that ATP certification, can you describe what that process was like for you and any recommendations you might have for other clinicians who are considering choosing this path?
Sure. As I talk to a lot of different people in the industry, I laugh kind of jokingly that you ask people how they got into it, and is it kind of by accident? Um, I don't think anything's ever by accident. I think you already have these passion and values for providing care and want to help others. That was where kind of I came from. Granted, my education within kinesiology and my master's degree, but you understanding the biomechanics, physiology, anatomy of the body. Originally out of college, I didn't know what I wanted to do. I really didn't. But I knew my core, that what I was passionate about, and had the great fortune to shadow an individual as part of the actually hospital-based DME that I worked at. He was a PT, ironically enough, and there had been this opening for this mobility specialist, and I had a leader that said, "Hey, Kyle, with your background, this might be something you'd be interested." And I shadowed him for a couple months, and honestly, I just fell in love with it. I fell in love with helping those individuals regain some independence and mobility. I worked a lot with actually about a quarter or third of my business with pediatrics, and that is so rewarding. Seeing these little kids get around their home that they've never been to before. I can't even put it into words. And engaging with those family members. But from a therapist maybe who's already practicing and wants to get into more of the assistive technology piece of it and mobility, is you've got the foundation, you've got the clinical foundation, the education, you're already there. I would encourage you to look at RESNA's website. So RESNA is the Rehabilitation, Engineering, and Assistive Technology Society of North America. It's a mouthful. I sit on two boards with them. They're kind of the national coalition and overseeing the ATP certification. There is also, if there are current ATPs out there, there's an advanced certification, if you're not aware, called the SMS, the Seated Mobility Specialist. The ATP is really focused holistically on anything assistive tech, including speech, AAC devices, a lot of that, and that's actually a big part of that test. Now, granted, when I was practicing, I didn't focus within that. That's a very niche piece of it. I often, again, look at the whole care team holistically, engage the SLP and part of that. Now, I was engaged in the equipment and the positioning of that, but not in the actual programming and scanning techniques. Granted, with my certification, I just didn't have the comfortability, I would say. And I think that's an important piece of it too, to understand your scope of work and what you're comfortable with doing and engaging somebody who has more expertise within that, Kathleen. So if that answers your question.
Absolutely. And you mentioned a couple of different resources and websites that you recommend, but Are there any other resources that you would recommend for any of our viewers who are just interested in learning more about, proper techniques for evaluating and for adjusting proper wheelchair fit? Is there anything you would want to direct them to?
You bet. So, first, I'm biased, but I have to be working as part of the VGM group is my sister company, US Rehab. They do a lot of stuff for those complex rehab providers all across the country, not only from a business standpoint, but more importantly from an educational standpoint, and what the courses they offer to help ensure a competent and confident ATP or even rehab technology technician going into the scope. So that'd be the first one I'd recommend. The next, there's several national coalitions. One is NCART. It's a National Coalition for Assistive and Rehab Technology. The next is NARTS, NRRTS, which is the National Registry of Rehab Technology Suppliers. The next is the CTF, and they're more clinical based. So this might be one for some of the audience members that are PTOT or clinicians. Is the CTF, the Clinician Task Force. They actually just had a webinar the other day about telehealth and kind of that decisions tree, if that's appropriate for the claimant. The other thing I'd reference was RESNA. And also there's a free publication that I think anybody can subscribe to if they're involved in this kind of community, is the mobility management. You can just Google it and sign up, and they send actual paper and electronic versions. And the last thing is, I would bet if they're practicing within some sort of clinic or they have a relationship with a local DME or complex rehab supplier, is the manufacturer partners. They have so much education out there for anybody, whether it's the supplier or the clinician involved on their products, but also from educational CEs. They provide those too to look at specifics within this industry. So that was more than a few. There's a lot of them out there, but that's a good thing. There's a lot of resources.
That's great. And I'll actually include links to a lot of those references that you made in the video description below so that our viewers can find those as well. Well, Kyle, thanks so much for a great talk, and thank you so much for your time.
It's my pleasure. I appreciate being here, Kathleen, and I wish you and ReWalk the very best.
And to our viewers, we hope that you've been finding these talks interesting and useful. So don't forget to reach out in the comments section with some of the seating and positioning challenges that you have encountered and some of the solutions that you use in your clinical practice. Please also make sure to like and subscribe to this video using the buttons below. And feel free to also use that comment section to suggest any future talks or topics that you would like to see from the series. We hope you tune in with us again next episode, and see you next time.